Hello, clients, colleagues, and friends. Welcome, and thank you so much for joining us for the webinar. Today's presentation is built around our recently released 2025 ECG MD Ranger benchmarks, data that reflect real-world provider contracting decisions across hundreds of hospitals. Clark Boslett, my co-host, and I are going to explore how compensation models are evolving, where market pressures may be intensifying, and what this all means for compliance and governance in an evolving regulatory landscape. So whether you're in strategy, provider compensation, finance, legal, compliance, Clark and I hope to have a conversation today that validates some of the challenges that you may be facing, and we're going to offer some practical and tactical advice. For those of you who haven't met me, hi, I'm Allison Pullins. I serve as Vice President of Product here at ECG. Over the past 18 or so years, I've worked with hundreds of hospitals and health systems, helping them navigate the intersections of compliance, strategy, and operational alignment with providers. I've hosted many webinars like this one, and I'm so excited to share what we've been seeing in the data over this past year. Clark, you want to introduce yourself?
Absolutely, Allison. Thank you so much for the invitation to join this webinar. My name is Clark Boslett. I'm a partner at ECG. I've been here for almost 15 years now, and I do work kind of exclusively in the same space that Allison described in terms of all of the different ways that health systems and providers can come together, whether it's direct employment, whether it's through service agreements, co-management arrangements, and things of that nature, as well as some of the compliance elements as well. So very excited to walk through these materials with you. I think we have some really kind of fascinating trends that we can talk about, and we really want to make sure we get into what's underneath, what's really driving those trends.
Yes, great. Thank you, Clark. So in terms of housekeeping, just wanted to let everyone know that if you have questions during the discussion, don't hesitate to pop them into the Q&A box. We have a couple of experts that work closely with us that will be answering questions in real time. So just go ahead and pop them in. We'll also have a few minutes at the end of the webinar to address some questions live. Okay, so here's how we'll be orienting our talk today. We're going to start with a look at those broader market forces that are shaping provider compensation. Then we'll dive into some of the key findings from our latest data. What's trending, what are some of those major challenges we see bubbling up, and even what has surprised us and what hasn't surprised us. We will wrap things up with a brief discussion on compliance, including recent enforcement activity and best practices for compensation governance and infrastructure, because those are really important when we're talking about provider arrangements of any kind, right? So for those of you who may not be familiar with ECG, we want to take a couple of moments just to share some facts and stats about our firm. ECG has been exclusively focused on healthcare for over 5 decades. Over 80% of our work comes from returning clients or referrals. Now, that kind of continuity and deep relationships give us more of a longitudinal view of how compensation and contracting models are evolving and how organizations that we work with are adapting. On this slide, we've collected just a portion of the organizations that we are so proud to work with here at ECG. Now, Clark and I work very closely with ECG's valuation practice, and given the nature of our discussion today, wanted to share a little bit more information about who they are and what they do for clients. So our practice conducts over 800 FMV assessments each year across all 50 US states. Now, these types of engagements expand multi-hospital systems, AMCs, rural hospitals, and pretty much every type of organization in between. Our work also includes litigation support, audits, and education. Now, this breadth of our practice really does allow us to see emerging patterns, whether it's shifts and trends and coverage models or new compliance risks. That's something that we're able to see at that bird's eye view. Now, In addition to our valuation practice, we also have a team full of compensation design experts. At ECG, we manage over 25 enterprise-wide engagements annually. We help large medical groups and health systems align their provider compensation with their overall strategy, which is, as you know, critically important. We've completed over 700 projects since 2000, and our expertise spans primary care, hospital-based arrangements, advanced practice providers, and more. Now, that depth and breadth really does matter when you're designing compensation models that need to be both competitive and compliant, and it's something that this team excels with. And lastly, one more slide, just a quick word about our provider compensation compliance products. Now, the Ranger products that you see on this slide are designed to reduce friction across all the teams that touch provider arrangements: compliance, finance, legal, business leaders, and to ensure compliance with federal regulations as well as your internal guidelines and policies. Now, many of you are likely familiar with MD Ranger. That is our flagship compliance product that streamlines internal policies to help document physician arrangements. Ranger FMV, which is our latest product in the Ranger ecosystem, helps organizations externally validate those arrangements by producing instant automated FMV opinions that are backed by our experts here at ECG. Okay, so Clark, I'm really excited to dive into some of the key trends that we're seeing across the country. Are you ready to get started?
Ready. Let's jump right in.
Great.
So there's going to be two overarching themes, two buzzwords that you're probably going to hear me repeat over and over again. And they're going to probably feel like they might be at odds at the surface level. One of them is, I think all parties have a desire for predictability. On the provider side, it is a predictable compensation package. It is a predictable clinical expectation. Where do I need to be? When do I need to be available? Those sorts of factors. And then on the health system side, I think it's financial predictability in terms of these are the suite of services that we need. This is the availability that we need or the on-site coverage that we need. I have a sense of what that should cost me over the course of the year. And how can we kind of stay within those parameters? Okay, that's the predictability part. However, we all know that there is some inherent variability. And so whatever we build from both parties' perspective has to be flexible, has to be able to flex up when the demand surges, flex back down so that you can have sustainability for your providers. And I think every party, agnostic of the service that we're talking about and how it's rendered, is trying to really balance those two things to actually create these kind of flexible, durable arrangements that everyone is seeking right now to make sure that you're not constantly trying to find and backfill service through locums or this kind of ever-present recruitment and retention challenges. So delving into this slide here. So I already talked about the desire for predictability from all parties. I do think that health systems are starting to become far more aware and far more sophisticated around measuring the presence and production of their providers, making sure that they always have their providers in an optimal setting, right? The examples of this are, and we're going to talk about this at great length, right? Using hospitalists, using advanced practitioners, using fellows if you have them, to kind of backfill some of your call coverage commitments, some of your inpatient coverage commitments, so that your subspecialists can be in the clinic like they need to be. They can be, if they're proceduralists, they can be in the OR, right? You want to make sure that you are deploying your providers in the most efficient way and getting them up to their peak of license. We all know that we're navigating an environment right now where there are subspecialty shortages in so many subspecialties. I do a lot of work in the pediatric space. It feels like every pediatric subspecialty is experiencing shortages right now. Many of the cognitive specialties are experiencing shortages, and that's overlaid on top of the melt that we're seeing across all providers in terms of what constitutes a 1.0 CFDE. So this kind of ties back into this desire for predictability and for sustainability. If you're a clinical professional, to basically say, okay, this is the parameters, right? This is how we define a 1.0 CFTE. It can be a mix of inpatient shifts, of outpatient or ambulatory clinics, of ORs, et cetera, all the different ways that you can be clinically deployed, patient facing, and really making sure that that's consistently defined in a way that, again, lends some predictability. But what we're really seeing and what we've been challenged with, really, it predates the pandemic. I think the pandemic really exacerbated it, and I don't know if we've really recovered, is this kind of melt, right? So, the 1.0 FTE going down to a 0.8 FTE, the 0.8 FTE going down to a 0.6 FTE. So what I am experiencing with a lot of the health systems that I work with is their headcount is as high as ever, but their actual FTE or CFTE is kind of melting year over year. And what counts as a CFTE is potentially even diminishing a little bit as well. And I think that's created some very real challenges for health systems, is again, they're trying to focus on maintaining coverage, maintaining patient access, et cetera. This fourth one here, really reviewing your provider leadership infrastructure. MD Ranger has tremendous benchmarks that everyone on this webinar is hopefully accessing to understand, what is the traditional commitment, the overall investment for certain leadership positions, what is the time commitment, what is the hourly rate, and obviously how do the two things come together to inform the total investment. One of the things that we're going to be showing you is how those numbers have evolved over time. But I think health systems really are hyper-focused on avoiding redundancies, right-sizing those roles, making sure they're clearly defined, making sure that they live within the correct org chart or infrastructure so that people do have the right line of visibility, the right accountability structure, and again, making sure that you're avoiding any duplication of roles. And then the last piece here is, and this may be a little bit regional in nature. However, it feels like even that is starting to erode. I talk about the focus on physician engagement and alignment vehicles. What I'm really talking about is we are seeing an uptick in interest from providers as they have evolved into a more direct employment mechanisms or closer alignment in states where they can't be directly employed, where there's suddenly a surge of interest in collective bargaining or in unionization. And I've been involved in many of those discussions. And what I consistently am in my takeaway is, gosh, this is really just an engagement issue. This is really just a matter of physicians who feel like they are functioning as purely employees, who don't feel like they have a seat at the table, who don't feel like they can voice their opinions and try to improve care and try to improve all the things we've already talked about, how their FTE is defined, what is their clinical commitment, and if there are incentives, what actually drives those. And so I've really worked with a lot of organizations to try to put that thought, think about provider engagement, physician engagement, put that at the forefront of everything that you're doing, every initiative that you have. How can we get more providers involved? How can we give them a very real voice in this conversation? And how can we create incentives that actually drive true alignment where, I say this all the time, the rising tide truly does lift all boats. It helps the health system and it helps the providers. And I think there are some very real opportunities to do that and avoid this kind of antagonistic us versus them mentality with the health system and the providers. Okay, let's jump ahead. I won't talk that much on every slide, I promise. So this one, difficult to recruit physician specialties. And we're actually going to get into a lot of this. What's driving it? It's everything we've already talked about. It's making sure that you have a sustainable work-life balance, very clearly defined FTE expectations. But some of these things are outside of your control. You can manage, you can mitigate, but you cannot completely, do anything about an aging provider workforce, the influence of private equity in the market, the evolution towards, there are specialties that have really adopted telemedicine. Radiology obviously comes to mind at the forefront of that, but many other specialties are doing, evolving into a telespace that is, I think, honestly, probably for the best. I do think that it creates better work-life balance and can create additional clinical capacity, but it's tough to navigate. you have, all of these kind of macro market factors. We are dealing with an aging population. We are dealing with, some very real unknowns going forward based out of HR1 in terms of what's going to happen with Medicaid state level spending and how those dollars can be allocated across that population. We know that we have an aging population. We know that we are seeing a rise in chronic illness that's going to require complex multi-specialty care teams. And so all of these factors are happening. Physicians, their jobs are getting, and I should say providers at all, they are getting more complex. The job requires a little bit more resilience, a little bit more flexibility, because one day you might be in an outpatient clinic, one day you might be in a multi-specialty clinic, on your main campus, one day you might be in the OR, and that creates very real challenges in terms of measuring effort in a fair and equitable way that truly captures all of the different ways that providers can provide value to the health system and to the patient population. And so these are all very real challenges. We are going to get into some of the specialties where we are seeing the most acute challenges in terms of recruitment and retention, and some challenges in terms of getting certain specialties to provide inpatient coverage, provide call coverage, and what's really driving that. So let's jump in. We're going to spend a lot of time today, or at least in my section, talking about two specialties that we're seeing some of the most, I like to use the word froth. It's a little bit euphemistic, but some choppiness in the market. Anesthesia is number one. Radiology will be number two. And we're going to really try to understand what's driving it and what health systems can actually do to manage and mitigate it. Okay, let's jump right ahead. What is going on in anesthesia? Whatever it is, it has been going on for a long time now. The challenges that we're seeing in the anesthesia market actually all predate the pandemic. Everything that is creating this swirl was already creating this swirl before the pandemic started. I think that, and it has really kind of continued unabated. If you look at the trend lines for compensation, if you look at the trend lines for subsidization, they have all really continued without anything really affecting their trajectory. So what's driving this? It's really three factors. There is a shortage, point blank, there is a shortage. For every 5 anesthesiologists who retire, 4 of them are replaced by new grads. And so there is a very real shortage in terms of anesthesia capacity that is being partially backfilled by advanced practitioners. But again, A plus B does not equal the actual pent-up demand in the market. And so you are seeing a lot of froth, a lot of year-over-year increases in compensation for physicians, for advanced practitioners who are working in a medically directed model, and even for advanced practitioners. And when I say that, I mean CRNAs and CAAs, and for CRNAs who are working independently. All of them are seeing compensation increase over time. You're also seeing an increased demand for subspecialization. So we've seen big increases in compensation for pediatric anesthesia, for CV anesthesia, for transplant anesthesia, for some of those subspecializations. Again, supply simply cannot keep up with demand. The challenge here is when, so obviously supply side, it's going down, demand side is going up. There's more anesthetizing sites. There's more non-operating room anesthesia or NORA sites that we're seeing. This is your endo suites, things like that. OB is another example. And the challenge is, this kind of new stage of anesthesia deployment is not as efficient as kind of the core OR space where they, I think, have historically practiced. And all of that is to say that as their deployment actually goes up, and there are more FTEs working in the hospital, their production and their revenue is not necessarily going to keep pace. And so unfortunately, that's going to only cause more and more of a subsidy as you continue to put anesthesiologists in less clinically efficient or ASA unit dense settings. So again, we talked about the proliferation of NORA sites, evening, weekend coverage models, and even surgical flip rooms. These are all things that might be good for the health system as a whole, but not necessarily good for anesthesia production, and it will ultimately require additional subsidy. The last piece, the reimbursement challenges. Again, this is probably not breaking news for anybody. Medicaid, Medicare has never paid very well for anesthesia. What's changed is commercial payers, who have always kind of historically had to kind of backfill and make up the difference, have kind of put their foot down. And so we really haven't seen any increase in terms of reimbursement for anesthesia from commercial payers at all over the last 5 years. That line has been very flat. And so the overall reimbursement has stayed very, very flat or even dipped down on a per unit basis. The No Surprises Act that came out a couple of years ago has further diminished groups' ability to negotiate with commercial payers from a leverage standpoint. And so there is not going to be on the payer side any kind of white knight to ride in and save the day. So these challenges, unfortunately, I think at this point are fairly systemic, which means it falls on the health system to think really critically about how much anesthesia capacity do you really need. So let's jump ahead and we'll show you some kind of charts and graphs that make this real. This is the projected provider demographics. Again, you can see it's not super clear, but you can see that bottom bar, the MDs, that head count is projected to kind of further erode through the end of this decade, and only at the beginning of next decade do we expect that kind of curve to start to tick back up, which would indicate more providers entering the workforce than leaving it. You do see an incredible uptick of CRNAs plus CAAs entering the market, which is a good thing. More and more states are letting CRNAs practice independently. More and more states are letting CAAs practice at all. Again, that's a very positive thing for the supply and demand misalignment, but it's not going to be a quick fix. We're talking about a 5-year horizon to actually see some improvement on that. So I don't think there's going to be a quick fix in terms of the loss per FTE or the subsidization per FTE that we're seeing right now in anesthesia. On the next slide, we're going to jump right into, again, this is the brutal truth right now. If you're on the cost side, if you're an anesthesiologist or a CRNA, maybe not so bad, but your compensation is increasing really fast. So this is general anesthesia. This is just adult general anesthesia. The numbers, like I said, are much higher for CV anesthesia. They're even higher now for pediatric anesthesia. This is going to be all-in cost. So this is compensation and benefits at the median on the left, the 75th on the right, and you can see these are eye-opening numbers. Not that long ago, you could pencil in general anesthesia cost to the health system being, $525, $530, $535, and that was a steady state for a few years. And then you saw a very marked increase with a, basically year-over-year change of the most recent year, 9%, which is incredible. But even over that broader horizon, you're seeing a 6% compound annual growth factor. So that's substantial change. That's at the median. You can see it's not really a very different story at the 75th. So really up and down the benchmark spectrum, you are seeing material increases in the cost. And again, that's compensation plus benefits, but the benefit load hasn't really changed. Maybe some med mal costs rising a little bit, but mostly this is driven by total cash compensation. On the next slide, we have the CRNAs. Same story. Very rapid increases here on the CRNA side and at the median and at the 75th. What I will say, again, I know I'm not breaking any news. What I will say is I expect two things to happen. I do expect on the medically directed side, there is a point where CRNAs can actually price themselves out of coverage models, which is to say there is an inflection point where groups might say, you know what, we're just going to go to an MD only model if we can achieve a 3-to-1 or 4-to-1 coverage model ratio. So while I think that compensation for independent CRNAs that can practice independently will continue to rise, I think the compensation for CRNAs that have to be medically directed, that in our state that they can't work independently or simply at a facility where they can't work independently, we are going to actually see a little bit of a bending of that curve and a flattening of that curve. And I actually think that we're going to probably start seeing two different benchmarks, one for independent CRNAs and one for CRNAs that have to work in a medically directed or medically supervised model. So I do think that's going to influence these numbers on a go-forward basis. Awesome. Let's jump ahead. I know I'm probably going over my allotted time. I'll keep this very simple. What does the system want? What does the anesthesiology group want? Again, it's everything I've already talked about. It's predictability, right? It's predictability, it's flexibility. The systems want to know that their rooms are going to be covered, that late add cases can be facilitated, that there's a degree of financial transparency. If there's a medical group coming to them and saying we need more and more from a subsidy standpoint, there is going to be an expectation for financial transparency. What are the costs that are really driving this? From the medical group side or the anesthesia side, It's going to be, recruitment support, potentially retention support, things like that. And it's going to be, hey, if we do, if we're scheduled to stay here until 3 or 5 in the afternoon, and you suddenly add a late ad case, and that's going to start at 4:30 and keep us here until 7:30, and I've suddenly got to call somebody and have somebody pick up the kid from soccer or take care of dinner, or all those things that are just happening in the vicissitudes of life, then that's going to cost something, right? There has to be some sort of a financial payout for that. And so you can have the flexibility, but it is going to come at a cost. And again, that's challenging, but it's absolutely something that health systems across the country are navigating, and they are building these, again, flexible and durable service agreements to make sure that all parties feel like they're getting value for what they're doing. Let's jump ahead. We'll jump into radiology now. You're going to see there are some thematic consistencies here. In the world of radiology, demand has spiked, right? So it's actually not as much on the supply side. The supply side for radiology, yes, they're an aging population, so they're dealing a little bit with what we talked about with anesthesia, but it's far more about the number of reads that are coming out of, hospitals, of ambulatory settings, has just skyrocketed. And there is simply, I think, the current cohort of radiologists has struggled to absorb that, even as they've become more efficient, even as they've adopted, teleradiology. We are seeing what we lovingly call the Uberization of radiology. So it's the ability for a radiologist to kind of choose their own adventure from a career standpoint. They can work for multiple facilities or groups. They can hop on, hop off at their own discretion. And if there is a surge, right, if there's a health system that is experiencing delayed turnaround times, they can basically hop back in and take advantage of what is functionally surge pricing. So all of the same things that we've probably grown to love or hate about, other elements of the gig economy are actually influencing radiology in a really fascinating way. But there are some silver linings here. So I'm not going to sound as fatalistic as I probably did about anesthesia. I actually think there are some mechanisms in the market there. AI is very real. You've got some ability to kind of swaddle radiologists with efficiencies in terms of the tech stack that they're using, in terms of some documentation mechanisms that can actually make them far more efficient at their job. And I actually think, again, the Uberization of radiology can be a good thing if we can harness this workforce and reallocate them in the most efficient manner possible, because you can actually level load, take advantage of some pent-up capacity in one market, and have them help with another market that's absolutely swamped. We're actually seeing kind of this systemization of radiology that health systems are bringing to the table to kind of say, hey, look, collectively, we know that we have enough capacity. It's just about having the ability from a technology standpoint, from an incentive standpoint, to make sure that our radiologists can be reallocated, redeployed, and handle cases from different settings. And so I actually do think that we're actually at a very exciting inflection point in radiology, where we're going to see some very real market innovation that is going to help address this surge in demand. On the next slide, we'll talk a little bit about this. Again, right now, and I'm gonna speak over this very briefly. I know this is very wordy. We are seeing double-digit spikes in terms of increases compensation for radiology. We have some slides behind this that'll show that, which is really fascinating. For a decade, radiology compensation was flat, and reimbursement was actually ticking down. And so it was a little bit of a tough moment for radiology. I worked with a lot of groups that were struggling to recruit and retain, because nobody wants to be paid less one year than the year before. But again, surge in demand created that misalignment between supply and demand, and actually saw, like I said, double-digit spikes for the last 2 years now in the benchmarks for radiology. So there definitely is a very real push in the market. But a lot of the things that I said on the with anesthesia in terms of the subspecialization, neuro, mammo, are two specialties where we're seeing very real shortages in terms of that specialization. And then the demand for after hours availability for urgent and emergent reads is another huge factor that we're seeing. So the availability of nighttime providers to read at a high level of quality and a high level of responsiveness has been a very real challenge for the market to absorb. Let's jump ahead. Again, this is the slide that bears that out. So you can see really flat, very, minimal increase back from going all the way back to 2014, all the way through 2023. So nearly a decade of relatively flat compensation for diagnostic radiology. And the line for IR was higher, but was also relatively flat. And then in the last couple of years, it's really ticked up. I'll be very brief. My prognostication, my crystal ball for radiology is that we are actually going to see a little bit of a flattening for the conversion factor for diagnostic radiology in a remote space. I think we're going to still see a lot of market pressure and some premiums for IR, some premiums for anything that requires on-site service. But as more and more RADs evolve to a remote setting, I do think we're going to see, I don't want to call it the commoditization, but we are going to see a little bit of a flattening of radiology for those plain film basic reads. But I think you are still going to see premiums for anything on-site, for anything overnight, weekend, things like that, and for neuro and mammo, where we are still going to see a shortage in terms of those subspecializations in the market. And then this really, probably intuitive, right? So for a long time, health systems didn't have to subsidize radiology. I think that's what makes this so hard to absorb. Anesthesia has been subsidized for a long time now. Radiology was a service line that functioned in the black for a very long time, and only recently is it now needing to be subsidized. And this is very fascinating. We're working at academic medical centers that already have very complex funds flows that were reliant on radiology to be a giver in kind of a giver-taker economy. And in reality now, they're having to be subsidized just like many of their other department peers. And so this has created a very real challenge for health systems to absorb, yet another service line that's requiring subsidization. And it's requiring subsidization at a rate of growth that has been very challenging to absorb. And you can see here in the most recent benchmarks, we're seeing, 150 to 200K per FTE in subsidization for radiology. And again, 5 years ago, that number was 0. So that can be very challenging to absorb. All right. And I'm going to go just super briefly through this. So what is the response to this? I think it's making sure that you have a very clearly rationalized understanding of how much radiology capacity do we really need. It's making sure that you're building compensation plans or service agreements that incentivize anything on site, anything after hours, anything subspecialized. It's trying to tighten your alignment, making sure you have incentives around turnaround time and things like that in your contracts. It's looking at, teleradiology solutions. It's looking at investment in technology. Again, I hate talking about AI because everyone's talking about AI, and when everyone talks about it, it starts to lose meaning. But AI is going to be making a very meaningful impact in the next few years in radiology, making radiology more efficient and hopefully driving down the cost of actually delivering radiology services. And one thing that's interesting, this is always a little bit of a canary in the coal mine, CMS in their projected reimbursement for radiology next year in 2026 is actually ticking down their reimbursement on a per read basis. So I think in anticipation of radiology being rendered a little bit more efficiently. So I do think that there are some kind of macro market factors that are going to help out. But I do think we're probably primed for a couple more years of pain with your radiology partner as you try to absorb the sudden jolt in demand for their services and the corresponding jolt in the compensation per FTE.
Yeah. Thanks, Clark. I really appreciated that deep dive into those two specialties. And I have to say, I was at the American Association of Provider Compensation Professionals conference in April, and there was just so much chatter about both anesthesia and radiology. So we really know that organizations across the country are grappling with issues in these specialties.
Absolutely. All right, Allison, I know I'm up for the next section too. I'm sure everyone on this webinar is probably tired of my voice at this point, so I'm going to go through this pretty quickly and efficiently, hopefully. I mentioned earlier the use of hospitalists. That has been really fascinating to watch throughout really the duration of my career and even predating my role at ECG. This kind of evolution towards subspecialized hospital medicine So rather than being kind of the stem cells that could be reallocated anywhere within a health system or within an inpatient facility, we're now seeing greater subspecialization. What we've highlighted here is OB hospitalists, pediatric hospitalists, but you have CV hospitalists, you have oncology, you have hospitalists working in almost all of the kind of major specialties in an inpatient setting, which again is a positive thing because it's freeing up some of those subspecialists to be in more clinically efficient settings. But basically, what's the big takeaway here? Yes, you can continue to expect to see year-over-year increases for some of those subspecialized hospitalists, but the cost for general hospital medicine has actually been fairly flat. The other thing that I say a lot about hospital medicine is if there's ever a group to build a sophisticated incentive model, this is if they're directly employed, if they're PSA'd, however you are contracting with your hospitalists, hospital medicine has such a span of influence to drive down length of stay, to drive down readmission rates, to do all of these things that help the finances of the hospital, and just make sure that you invest the time, engage with your hospitalists, and build really sophisticated incentives because they can really create meaningful change in the halls of your facilities.
Yeah, so important for clinical quality too.
Absolutely, absolutely. They can drive down hospital-borne infections, all of those different things. They are so incredibly valuable to a hospital. And here, this actually gets right to it. So where are we actually seeing incentives? This is a fascinating kind of 5-year look. So 2020 to 2025, you can see that the number of contracts have actually dipped, or the number of contracts that have these incentives have actually dipped down across the board a little bit. That ties back to what I said at the top of the webinar, which is we're actually seeing fewer dollars at risk. So for every $1 that you're going to spend, for a long time, every single year, more and more and more, a greater percentage of that dollar was put at risk. We're actually seeing a bend where these last 2 years, our survey has shown that more dollars are guaranteed, an uptick in terms of year-over-year change in terms of guaranteed dollars than the year prior. And I think it is that desire for predictability. That is not to say that we are getting away from creating incentives. I still think that these are an incredibly valuable alignment tool, but I think the total portion of dollars that are put at risk is actually going down a little bit in response to that desire for predictability. And we are seeing probably the biggest drops in terms of things like patient satisfaction. We still see a heavy focus on quality. I think you should always have incentives tied to quality as long as they can be meaningfully and objectively measured. And then we are kind of continuing to see that erosion of costs there on the far right. It's just such a hard thing to actually hold individual providers accountable to that I think that continues to be a little bit less popular. Okay, administrative side. This is really fascinating as well. This tells such a clear story, and it aligns so clearly or so cleanly with what I have seen in the market. You see, I want to focus on the bar charts on the right. In the middle bar chart, the hourly rate. What you see is over the course of this 6 years, so five year-over-year trend lines, we can see almost no movement in terms of the hourly rate. The hourly rate for administrative time has stayed relatively static. It had been ticking up. So that top gray part is where you've seen change of greater than 10%. Ticked up a little bit, but even that has now really kind of stagnated. The dollar per hour for administrative services has largely stayed static. However, annual payments we've seen up, down, and that is because the number of hours has been very, very carefully recalibrated. And I love this because that tells me that everything I said earlier, that health systems are taking a very sophisticated lens at what positions do we need next year. They're not just carrying them over year, they're actually revisiting them. We're willing to invest in a larger share of dollars for this new program back when it was brand new. Now that it's established, we're going to pull dollars back from that role and give it to the next kind of nascent building program that we're prioritizing. that's perfect, right? So I love that I'm seeing this. This is exactly the kind of year-over-year change that I'd like to see. Relative stability in terms of the hourly rate, but a little bit, you can see it's not quite a third, but it's probably 20% up, 20% down, and 60% staying relatively static in terms of the total annual hours, which is exactly what you would want to see from a health system that is carefully recalibrating their administrative needs year over year. Okay, this is actually breaking it down. And again, we're giving you a full decade of data to kind of establish the trend line. This is showing the annual administrative spend per service. This is not surprising because there's really not been a significant change. For medical specialty, it's basically flat. For surgical specialties, it's ticked down a little bit. And then you can see here on the right, the leadership positions, there was kind of an apparent spike a little bit back in 2018, but that has stayed relatively flat. And for non-director administrative services, it had been relatively flat, a little spike this year. What this tells me is, I think, and this is very much aligned with what I've seen in the market, health systems are really scrutinizing where they're pulling surgeons out of a clinical setting and putting them into an administrative role, because there is undeniably an opportunity cost there. Other than that, this has stayed relatively flat in aggregate, right? We talked about on the prior slide, individual roles are going up and down, but the aggregate spend for administrative services should be relatively flat for a health system, or at least relatively aligned with total system revenue. It should not be spiking out of alignment with that. So if you are experiencing growth, yes, you will inherently have some administrative growth, but it should be roughly aligned with metrics like patient revenue, with metrics like encounters, things like that. And then the next one here, so the administrative hourly rate, like I said, these have been relatively static. We're showing you the 25th, median, 75th, and 90th. You can see there has not been massive change for any of these. You're seeing some uptick at the 90th, which is probably intuitive, but really across the board, I think the takeaway here is that the rate per hour has been relatively static. I think that's actually a good thing. And interestingly, that's static in an environment where other things have gone up, right? So I would actually say that this actually shows a little bit of an erosion in terms of the dollar per hour, because you know that the clinical hour, the cost is definitely driven up over the last decade.
Yeah, it's an interesting point.
So the time spent in administrative roles, and this is, again, very fascinating. We're just giving you 3 years here to absorb. Again, what we're seeing here is relative consistency, which I think makes sense. A little uptick in utilization management, which actually makes total sense, because every health system I'm working with is absolutely hyper focused on utilization management, on everything that entails, on managing their supplies, managing how everybody is deployed, basically thinking about the cost structure, and where you can drive down cost. That has been an absolute focus of health systems over the last few years, and they are willing to allocate dollars and time to make sure that is happening. Other than that, relatively static. The only thing I'll say on this is there was a slight uptick in research and teaching. You can see that is third from the right. I'm very curious to see what that looks like next year, because we know that there are all kinds of headwinds facing academic medical centers, where research dollars are getting pulled back, and they are getting tighter and tighter and harder to win for your young researchers. I think it is going to be harder for health systems to invest, certainly if they are having to originate those dollars themselves. If it is not externally funded research, I think it's going to be harder and harder to rationalize those dollars. And so I do expect that to start ticking down, unfortunately. And the last piece here, I think, so the highest paid leadership and non-director administrative roles, again, relatively flat. Utilization management going up. If you notice, that actually went up almost in perfect lockstep with the prior slide. So prior slide was hours. This one is total payment. That aligns perfectly. The interesting thing here, the last slide showed chief of staff hour allocation being flat. This slide shows an uptick in investment. What that tells me, there has been a trend for a few years now where it's a bit of an erosion of the traditional chief operating officer role, and many of those functions are being backfilled by a chief of staff. So that chief of staff role has been elevated in many health systems to take on some of those operational functions. And this supports that is, so what this tells me is that hours are flat, comp is going up. So that rate per hour is going up. And I think that is reflective of their additional responsibilities.
Thanks, Clark. That was a great overview of some of those leadership and admin trends that we're seeing. So I'm going to take a couple minutes to talk about ED call. I think ED call coverage remains one of the more challenging and at times frustrating elements of contracting with physicians. Interestingly, this year, 63% of our ED call benchmarks increased at the median, and this was a far larger cohort of benchmarks that increased in 2023 or 2024. So what is that telling us? Well, we are seeing that hospitals are under pretty strong pressure to maintain that coverage, often with very limited leverage. And the financial burden of these arrangements are growing year over year. So, Clark, I'd love for your thoughts here. What advice would you offer hospitals that are currently paying for ED call to help them relieve perhaps some of that pressure that they're feeling as they negotiate these contracts?
Allison, I'll try to be brief. I mean, so where we're seeing the biggest challenges here is in specialties like urology, GI, ENT. I always kind of joke, it's all of those specialties where, let them sit in their clinic, let them sit in their ASC, and basically anything outpatient, right? That's where they can churn. That's where they can really be very clinically efficient. Anything that requires them to be on site in an inpatient setting, whether that's rounding on patients, whether that's just being available for call, represents an opportunity cost. And what we're seeing is they are pushing back like they never have before in saying, we really don't want to prioritize this. We're having to cancel clinics, we're having to cancel cases to come in and do some of these things. And so health systems they're basically asking for more and more money, and health systems are struggling again to rationalize and absorb the idea of paying more for some of that call. So what's the solution? It's everything we've talked about. It's utilization of hospitalists. It's utilization of fellows. It's utilization of advanced practitioners, taking some of that burden off of those subspecialists to let them be in their ambulatory environment and actually kind of backfilling some of that capacity with some of those potentially lower cost providers. I think that's A. And then B is just, again, really trying to tighten the alignment. We are seeing co-management as a helpful tool to say, hey, look, we absolutely need you all to be invested in the services that are rendered here at the hospital. And so we're going to throw some additional dollars. We're going to put them at risk, things tied to quality, things tied to programmatic growth, to make sure that they still have a vested interest in the success of that program in its inpatient environment. So I think those are a couple of different things that health systems can do to try to help with this, but it is a very real pain point. There's a handful of specialties that have become increasingly challenging to successfully build financially sustainable models.
Great, Clark. Thank you so much. That's super helpful advice. I hope no one hears that. My smoke alarm appears to be going off. Hold on just 1 second. Clark, do you think you could take this slide?
I can absolutely take these slides. You can go ahead and mute and I can drive through this. So what we're seeing over time, so again, what you can probably immediately jumps out to you is again, what we've done is broken this out, 25th median, 75th and 90th. And it's really fascinating. So we've got medical and we've got surgical. Again, this is broad, so it's a little bit challenging to take much from this, but what this is saying is that kind of at the 25th in the median, we haven't seen a ton of change. The CAGR for those rates is going to be, around 1 or 2% for those lower levels. But you can see huge froth at the top of the market, right? So 75th, 90th, and what this tells you is that it is hyper localized, right? It is very much, situation by situation. We are seeing some health systems that are really, really struggling to fill some of these call arrangements, and they are having to pay massive premiums. So we are seeing huge jolts at the upper percentiles, 75th and 90th, less so for the lower percentiles.
Thanks, Clark. Smoke alarm is over. We're all safe here. Sorry about that. Okay, so the gap between the medical and the surgical call rates, as you'll see with this slide, do continue to widen. In 2025, surgical specialties did command a median per diem rate of $960 compared to $650 for those medical subspecialists. Now, that's a nearly 50% difference. And, again, like just to reiterate some of the things that Clark has said, these disparities reflect opportunity costs, they reflect market dynamics. So there are several stories going on as to why we see the data as it is. Now, some specialties have seen more dramatic increase in rates than others, and we want to show you that on this slide. So, for example, pediatric orthopedic surgery nearly doubled over the past 5 years. GI and oral maxillofacial also saw some significant jumps. Clark, I'm curious, just as you look at this slide, what are your key takeaways when you see some of these specialties appearing?
Exactly what we just said. It's GI, ENT, urology. These are all specialists that, again, for the most part, ortho, that can be so efficient in their clinic, oftentimes they have an ambulatory surgery center that they work at. And so, having them actually come in and cover an inpatient facility represents an opportunity cost. And you are seeing that a massive, massive premium. There's a couple other ones here, oral maxillofacial, craniofacial. I think that's actually driven a little bit more by the subspecialty shortages that we're seeing there. Those can be very challenging. Obviously, those are our cases, which luckily are not very predictable and consistent. And so you are starting to see a little bit of a challenge of, again, buying the capacity to have those people actually cover. But usually those are structured more as a relatively low kind of flat rate for availability and then an activation premium, because it's kind of you don't usually get a case, but when you do, it takes up your whole day kind of a thing. And so you see those structured. And I think that's probably what you're seeing driving up the rates in those two specialties.
Got it. Okay, so what specialties are most likely to be paid call? So with our unique subscription model here at ECG with MD Ranger, we can calculate of the hospitals that participate, what percentage of them are actually paying for a service in the first place. So this is a metric that we calculate that can be helpful for that commercial reasonableness assessment and documentation. So when I look at this slide, I kind of see the usual suspects appearing, right? Orthopedics, urology, general surgery, GI. These are the most frequently paid services year after year. And these are the hospitals that are, these are the specialties that hospitals are most frequently paying. Believe this may be our last data slide for call. It is. So what are the highest medium per diems? What are the specialties that facilities need to pay the most to obtain coverage for? So this probably isn't surprising to anyone, but trauma surgery and orthopedic trauma surgery lead the pack with very high median per diem rates. And again, this isn't even P75 or P90. Now, as you can see, the services listed on this slide are high acuity. They're increasingly challenging to staff. So we're really not surprised to see these specialties flesh out the top highest paid ED call per diems. Okay, so with the little time we have left today, we do want to spend a couple of minutes reviewing legal and compliance considerations that truly come in lockstep with any discussion about provider compensation. So with enforcement activity really on the rise, we all know that compliance isn't just the compliance team concern anymore, right? It's really an imperative across the C-suite, across physicians and other providers, and frankly, the organization at large. So compensation arrangements with your providers need to be defensible, they need to be well documented, and they absolutely need to be aligned with standards of both commercial reasonableness and fair market value. So we're going to review some key takeaways for compliance and share some really practical strategies on how to create and maintain policies that actually work and mitigate risk. Now, we recognize, and we've talked about some of them today, that there have been a lot of changes in Washington. But if anything, enforcement activity is accelerating because it recovers a lot of funds. So the Department of Justice really does continue to prioritize pursuing healthcare fraud, the return on investment is truly substantial. So you can see they recovered $2.9 billion last fiscal year. Almost 70% of it was from healthcare alone. So this is a big mechanism for the government to protect us as taxpayers and ensure that we are recovering those dollars lost to fraud. So the false claims you can see in federal fraud abuse activity on this slide, False Claims Act settlements rose nearly 55% year over year, and the self-disclosure settlements hit a record high. So you can see on this slide that the government recovered $71.9 million through the self-referral disclosure protocol. Now, what does this tell us? So these trends, if they don't already, really should underscore for you the importance of proactive compliance and solid documentation habits. So let's go over Stark, the Anti-Kickback, and the False Claims Act. These, and Clark and I could probably do an entire 2-hour webinar on these regulations, but we'll take 2 minutes. These regulations form the backbone of federal oversight for provider arrangements. So at a very high level, Stark prohibits self-referrals. The Anti-Kickback targets remuneration or bribery, and the False Claims Act is going to address fraud that involve federal programs, right? So understanding how these regulations intersect with compensation strategy is really essential for your compliance program and for your organization at large. Now, it's critical to keep in mind that fair market value, it's not a fixed number. Gee, don't we all wish it were? It would make our lives easier. But instead, it is a range that is informed by both data as well as the context and the facts and circumstances of the arrangement in question. Now, FMV must reflect those facts and circumstances. It needs to be documented in a consistent and rigorous methodology. Okay, so thankfully, the OIG has outlined for us 7 key elements of effective compliance programs. These include things like written policies, leadership oversight, training, my personal favorite, communication, enforcement, auditing, and of course, corrective action to enforce all of your policies. Now, time logs, governance frameworks, external validation, and third-party independent opinions, these are all critical components. Now, our colleagues work with, and we mentioned this earlier in our webinar today, they work with dozens of organizations across the country to determine what are the best, most effective governance strategies for them. And if you need assistance with that, we are absolutely here to help. So what should a best-in-class compensation policy include? So a strong compensation policy needs to articulate your organization's philosophy and their principles on compensation. So this is really important to define. Then you need to look at roles and responsibilities, as well as establish a governance framework. Now, your policy should also specify what approved market data and benchmarking sources that you can use, and you need to make sure that your definitions of total compensation, total cash compensation, and what an FTE is are also clear within this framework. Again, this is not just about documentation for documentation's sake. This is about mitigating risk as much as you possibly can. And with that, I think it's time to, we'll leave you with this placemat, but it is time to answer some questions from our audience. Thanks again so much for having us today. We really appreciate it.
Thanks, everyone.